afternoon to all. I hope no one is feeling sleepy over here. I can understand after lunch, I can see that many people feel sleepy, huh? So let's start the session. But before deep diving into the today's agenda of deep learning in medical imaging, I just want to ask one question from everyone. And I really want everyone to respond over here. Let's try to make this session more interactive, okay? So just let me know how many of you used AI today? How many of you used AI today? That's my question. Very few people have raised the hand. Is it like that? So why I can just see 10% of the audience is just raising the hand. Can you just again raise the hand? How many of you just use AI today? Okay, can you just let me know, sir, where you have used today?
So one is Google Maps,
Okay.
one is Gemini.
Okay, superb, superb. Perfect. And next question is, how many of you recently had a CT scan or MRI scan? Anyone? Recently? In the past few months? Maybe?
In the family.
In the family. Okay. So today what we will discuss over here, we will try to combine these two use cases together, and we will try to see that how AI is being used nowadays in medical imaging tasks. So let's get started. I really want everyone to observe these three images: input, automatic segmentation, and manual segmentation. Anyone who can give me a brief analysis what you have observed in these three images? Anyone who wants to raise their hand and speak up over here? Yeah, please go ahead. Okay, so that sir has analyzed that few green dots are missing over here. Any other observation? Okay, great, great. Any other observation? Anyone?
Green is covering those dark spots, right? I mean, on the input side.
Okay.
And which is doing better? It's pretty close. Actually, maybe automatic segmentation is as good as better than manual.
Can you just speak up again that last line?
I think automatic segmentation seems to be doing better than manual. If you look at the top right one, I think manual segmentation is showing a little bit bigger green color on the top. Where the actual input is matching automatic segmentation more, I think.
Okay, so that's the visual representation with which we have observed these things, right? Anyone is doctor in this room? No. Anyone? No. So we all are not doctors, right? I'm assuming we all are engineers, but still we can observe over here. See, this is the input, which is the, if you can observe over here, this is the lever area, and this green things which you are observing over here, it's kind of a tumor, okay? And the process of detecting this green cells over here is what we called as, any guesses? Yes, please. Segmentation. So this process is what we called as image segmentation. So if you will carefully observe over here, the kind of results which we are getting in the automatic segmentation, when we are saying automatic, it is done by our deep learning model, okay? Automating our task. Manual segmentation is something which is done by experts, radiologists, right? So if you can observe over here, the kind of results that we are getting is very, very close to each other, right? That's the power of deep learning models that we have, deep learning architectures that we have. And that's why nowadays you will observe in almost all the kind of diseases, the automatic segmentation plays a very important, significant role, right? So you can see over here the applications in disease detection, diagnosis, image segmentation, quantitative analysis with precise and objective measurement, and high operational throughput. I'll try to explain each and every point step by step, but I hope that this image gives you a better idea that what I'm trying to convey over here. Now, what are those deep learning architectures which really helps us to get that done, automatic segmentation? So we have convolutional neural networks, CNN-based architectures, which basically helps us for image classification and segmentation task. Followed by, we will be having this capsule networks called as TechCaps. I think CNNs are very famous. I hope everyone have heard convolutional neural network. Yes? How many of you have heard seg caps? It's quite rare. Capsule networks. Only 1, 2, 3, 4, quite less, right? So today's task after this session definitely will be, because I have a limited time to explore this seg caps. It is also very powerful architecture which basically helps us to do the image segmentation task, and this is as powerful as CNNs. And that was my research area when I was pursuing my master's in AI from IIT Hyderabad. So what we have figured it out that the performance that SegCaps have given to us, it's comparative as comparable to CNNs as well. I will showcase you the results as well at the later stage. And at the very end, we have hybrid models where we are trying to combine these CNNs and SegCaps. I just give you a brief insight over here. SegCaps are non-convolutional neural networks. So whatever operations we have in CNNs, that is not there in SegCaps. Actually, it performs dynamic routing-based algorithm. I can understand these words are black box for many people. That's why I'm not going in that much advance over here. But I just want to give you a brief idea that these are the known CNN-based models, and the above one definitely is a CNN-based model. So the very famous medical imaging segmentation model is UNet++ and UNet, which is basically used to perform a lot of segmentation-based tasks. So here are the case studies and applications, and I'm pretty sure that you must have observed these case studies nowadays. One is skin cancer detection. How these, whatever be the case studies we have, maybe skin cancer, brain tumor, automated lung inflammation quantification, which was my research area. All of the case studies, if you will observe in the medical imaging, works on similar workflow, which I'll demonstrate you just after this slide. But any idea, anyone, that how these detection, segmentation, quantification usually happens? What could be the life cycle? Anyone, any guesses? What's the first step? Let's talk about the first step. Do we have a label data? In the medical imaging sector, do we have a label data? When I'm saying label data, for example, let's say brain tumor detection is the case study we are focusing on currently. So if, let's say, I will be having an original annotation, with respect to that annotation, do I have a manual segmented annotation as well by the experts, by the doctors? We do have, right? So what we are doing over here is, we are trying to train the models on top of that. Now what the models are doing, when I'm saying models like UNet++, SegCaps, UNet. So what those models are doing, they are trying to observe the patterns, just like the way we as a human being learns, right? If I'll call some kid and explain to him or her that what is cat, so how will you explain? Anyone? So do you explain some points? Step 1, step 2, step 3, step 4. Then what's a good idea? Show them lot of images, right? Everyone agrees with me? Okay? So we will try to showcase them lot of images. Automatically that kid will analyze the patterns, and then obviously they will be able to demonstrate a decision that, hey, it's a cat. Same thing happens for a model as well. It's like training a model, meaning that we are trying to find the patterns, which basically helps us to understand that, hey, there is a tumor available in that specific testing data. Make sense? So if you will be able to observe over here, now these are the images of my research work, which I am showcasing you over here. So the task was, so let me just give you a brief insight what we were doing over here. So that was the time of COVID, where we were having the COVID-based data, and the people who were suffering from COVID, they have that ground glass and consolidation. Can you see this white area over here and over here? This is what we call as ground glass. And if that white area is quite heavy, it means that that person should have, admitted to the ICU. Means that person is very serious, right? So we need to demonstrate, we need to find that automated segmentation to be done, so that my model will be able to analyze that, hey, this is the ground glass available over here. That's the task. So how basically the pipeline will work, and the same pipeline will work for all the medical image-based data, by the way. You will be having a annotated inflammation mask. Inflammation means infected mask we will be having. Annotations means that it is done by the radiologist, okay? So we will always have that original mapping available over here so that our model will learn the correct patterns. Once we do that, we'll try to do the shrinkage using the active contour. It's again a mathematical concept which is basically tries to shrink the portion of this white area so that we will be easily, or our model will be easily able to focus on that white area of glass door. After that, we will start our model training. Once the model training will be done, then we will come to the outcome. But here you can see, this is the original annotation where you can see this is the area, which is the infected area. This is the segmented by the expert. When I'm saying expert, in this case, in the medical imaging, I'm always talking about the doctors, okay? So this is the area which is shown by the experts that this is the infected area. And when we updated the shrunk mask by active contours, this is the area which we figured it out. So we did data pre-processing, and for model training, we have used this shrunk mask, not the original mask, because when you get the original images, they are quite huge. This portion is quite huge. You can see the infected portion. We need to shrunk it first, and then we have to train for the model training part. Now, what's next? So, till so far, what we have covered up. Any original data, we cannot pre-process directly. We need to do the pre-processing first, maybe via active contour. There are multiple algorithms for that, and we shrunk that. Once we do that, now there are the next steps where we have to find the region of interest, ROI. It's quite famous. I'll showcase you with picture. This is the CT scan we have. We have to focus on the region of interest to find the infected portion. So I'm focusing on this lung side, and this is my model which gives the result. This is the inflamed lung region, which we are calling it as glass or in consolidation. I hope it makes sense. So if you will be able to observe over here, what we are doing, we have an input CT scan. We are trying to generate the region of interest. On the other hand, we have the annotated inflamed mask. We are doing a pre-processing via? Very good, shrunk active contour. And after that, we are doing inflammation segmentation. Here we are applying the different algorithms that we will have discussed, the architectures. Finally, we are doing the quantification. I'll talk about this thing, how we are quantifying that inflamed region. Then we have some input clinical parameters, like the demographics of the patients. And finally, with the help of these two data points that we will be having, we are predicting that whether that patient requires the mechanical ventilation or not. The same case study you can apply for all the applications that we will be having in almost all the deep learning in medical imaging domain. So here you can see the quantification part. If you will be able to observe over here, when I'm saying quantification, the simple literal meaning is that we are trying to find the volume of this inflamed region divided by obviously the complete lung region volume, and that will help us to find the numeric number, which we called as all R's, full form is automated lesion to lung ratio. And with the help of this parameter, we will try to apply the machine learning model. You can apply any of the classification model over here. Maybe you can go with logistic regression, random forest, decision tree, whatever you feel is giving the better performance, better metric that basically helps us to analyze that whether we will have to basically ventilate that patient or not at the end of the day. By the way, all this analysis will be done with the help of the doctors. When I was pursuing my master's, and the data was taken from original patients from Jaipur hospital. So that was the whole idea about this specific case study. Now, if you have any sort of questions, you can ask. Thank you so much. I hope that it was insightful. Okay. So here, if you will be able to observe over here, there are multiple, by the way, CNN models we have. It's not alone. But every kind of CNN model works on the same case study or case theory. Well, how is that? Basically, it will try to apply the filters. Now, we do have different kind of filters depending upon what pattern you want to detect. And on top of the input layer, so when we are saying images, whether it is of MRI scan, CT scan, When we insert those images, internally those images will be treated like a pixel. So when you say 256 cross 256, there's a pixel tabular format. On top of this, filter will be overlapped, mathematical computation will happen, and it will try to give you a final result, which includes again a pixel matrix, which will be able to see the patterns available in the given data. And that's how you will be able to get that
What is the window size?
segmentation.
That window size you adopted 2 by 2
Okay.
or
So
5 by 5?
when we are dealing with the image-based data, it's a 3D based data. Okay? 3D means we are dealing with the 3 layers. Now, the problem or the issue with when we are talking about these medical image-based data, I was talking about this fact initially as well. What do you think are the problems when we're talking about the domain of medical imaging?
That depth, RGB is the problem. First, you are handling grayscale image, then you are extending to RGB, or how you handle here in this
No, it's a grayscale.
grayscale only?
Grayscale image. Now, what was the problem? What were the challenges? It's not easy like the way I have talked about. There were a lot of challenges, and even if there is someone who is working in the medical image-based data, they can understand. The very first issue when we're working with this domain, as mentioned by her, the label data is very, very less. And even doctors doesn't have the time to label it or to mark it, right? Radiologist doesn't have the time, but nowadays, because this AI-specific domain is quite booming, so obviously people are spending lot of time, lot of effort, lot of money doing the research about this specific domain, but still today, label data is something which still is not there. Second issue, anyone? Label data is an issue, that's correct.
Another one is a privacy concepts.
Very good. So, privacy concerns. Do you think that you will be easily able to access the patient's data? Today, if I really want to access any patient's data, so will the hospitals people will give me? Is that ethical? No. You need doctors to collaborate with them, and that is how you will be able to get the data set. Yes, we will be having open source data available on Kaggle, UCI repositories, but if you want to deal with the real-time data, obviously the results which you will be able to capture after training the model, whether your model is working fine or not, you have to work with the original data, which is the real-time data. Otherwise, how will you get the performance done? Right. I hope it makes sense. So this is the second important thing, which is quite difficult and challenging for people like us. Any other thing?
But for the privacy part that you talked about, if you don't give the patient details and just get the images, you don't really care about person's name, age, or whatever, right?
Exactly.
You only care about the images.
Exactly.
What is the harm in giving the data? I mean, if the patient's this thing is not.
What is the end goal?
I want to interfere, madam, legally
Yeah,
here.
please go ahead.
Because that DPDP or GDPR, whatever this says, privacy concerns about individual concern.
Yes,
So if ultimately anybody can prove that those images are belongs to X.
exactly.
Without by masking X also, you can use it. Later onwards, X can raise a claim that
Exactly.
my images are used for commercial purpose and they have gained without my consent.
That is the one thing. And second thing is, you always have to understand our end goal is not just to segment the images. Our end goal was to check that whether this patient actually requires ventilation or not. Without being human intervention, without, I don't want radiologists to see that images. Also, there's a lot of work going on the interpretability part. We are not really sure till so far that whatever be the model results going on, is that very much apt? Doctors replacement is, I don't think it will ever happen, but that will, with the help of these specific AI-based tools, obviously the time reduction will happen. And that is where this specific domain plays a very important role. Even the same thing happens for us as engineers. People usually get afraid that whether we will lose jobs because now GPT is there. There are a lot of LLM-based platforms are there, DeepSeek now coming up. What will happen about our jobs? All these platforms are basically for helping us. It's just that we should be aware that how can we use these platforms to help our task, in a quite shorter manner, right? That's the whole idea. And yes, please go ahead.
One question, I mean, I know we talked about the label data, and I wanted to understand what's the kind of a label data that we are looking at to be able to train a similar kind of a model, number one. Number two, what are some of the latest industry trends which are there to be able to achieve the similar amount of accuracy with a lesser amount of computer vision data, label data?
So talking about your first question, when we are talking about label data, it means that one thing, we will be having the original CT scans where this green mark will not be there. That is the meaning of original CT scans. Corresponding to every original CT scan, we will be having the segmented by expert. This is the segmentation result.
That's clear. All my question is how many number of such images you had to use?
It really depends. For me, it was about 1,000 of images, and we have trained on top of that. The only reason was, at my point of time when I was working, is I don't have that much label data available. That's what we have talked about few minutes back. When we're talking about the number of images, the more images you will be having, usually it is better until or unless your model is not overfitted. Then there are techniques to detect that as well, that whether our model is being overfitted or not. But definitely, this label data is something, as much as you can collect in the initial part of your process in your case study, that would be a better idea. I hope it answers your question.
And any industry?
Madam, what are your false positive and false negative metrics for this your thesis? How much you have achieved?
Okay. So when we're talking about this medical imaging domain, there are two metrics that we usually work with. One is called as DICE score. Another one is called as IOU. You can maybe research later on. DICE score, DICE-SCORE. Basically, when we're talking about this image segmentation based task, it usually tries to see that how much is the overlapping with respect to the segmented images in the segmented by expert part versus the automated segmentation part. It will try to see that how much is the intersection between these two images, and then it will give the result. By the way, my research paper was published at EMBC conference at IEEE. So at any point of time, you can Google it. This same name, automated lung inflammation, and IEEE Priya Bhatia, you will be able to get all the details, and you can download the research paper as well to see final metrics as well. I hope it answers all your questions. Thank you so much for your time and effort. Thanks a lot.